Okay, we're going to start, inshallah. I want to keep my own time. Many of you probably have a lot of things to get to, so do I. So, assalamu alaikum, everybody. Alhamdulillah, rabbil alameen, wa al-aqibatu lil-muttaqeen, wa as-salatu was-salamu ala ashrafil anbiya'i wal mursalin, wa ala alihi wa sahbihi ajma'in. Allahumma 'allimna bima yanfa'una wa yanfa'una bima tu'allimuna wa zidna bi fadlika 'ilman wa ta'liman innaka 'ala kulli shay'in qadir. I'm going to not be responding to chats, this chat thing. So if there's something that's really, I'm going to open it up at moments because I have some feedback for you. I want some feedback from you all, and then I'll look at the chat. But during the time I'm speaking, I'm not going to be looking at the chat. So and I know there's a way that you can ask Q&A, so I'll try to look at that intermittently when there's time for us to do so, inshallah. So Jazakallah khair, everybody, for coming. I appreciate Balagh Academy, Dr. Faqat, and others, and Mufti Abwal, for putting this series together. I don't know how many of you have actually attended the rest of the sessions. So there might be things that are overlap from things that you've heard. Unfortunately, I haven't attended any of the sessions, so I don't know what you've heard from other scholars. But we can have some discussion over that, inshallah, when there's time. So today, I'm going to cover a few different things. Let's see, there we go. So I know there was various emails and flyers sent out, but here's my idea of what I would like to talk about, and then I'm going to open it up to ask you if is there sufficient overlap from what was covered by Mufti Zubair yesterday, so that maybe we change some of these things. But my plan was to talk a little bit about withdrawing and withholding life support from an Islamic bioethical perspective, trying to tie together the ontological, then the theological notion of caring and healing, to the specific ethical legal judgments that we are using to base our current context off. I mean, the idea, obviously, this whole series is about COVID-19, so we're going to talk a little bit about how those extant rulings apply or do not apply to COVID-19 decision-making. The second thing I want to have a conversation over is the ethics of critical resource allocation or crisis standards of care. In pandemics, obviously, we're in the middle of COVID-19. This is not going to go away very quickly. And there are various points of contestation between stakeholders that are policymakers, doctors on the ground, bioethicists. So we're going to talk a little bit about these two, either the notion of crisis standards of care, and then the idea of prioritization rubric for individuals who might be receiving those scarce resources. And then I want to talk a little bit about Ramadan's coming, inshallah, next week. So the idea of congregational prayers and social distancing, specifically, we're going to talk about. So the first thing I want to present is didactic. The second, we're going to have a little bit of a conversation. I'm going to present some ideas. This last area, we're going to have some conversation over, and I'm going to let the mic sort of go out and you can speak. I believe I know how to do that, but if not, then we'll try to figure that out. About what the significance of prayers are. How are we thinking about this, right? And I mean by this, not just salah, but I mean congregational jama'ah. Then the significance of medical risk. What is the medical risk really? What are we talking about that muftis and doctors and everybody else are worried about in the context of congregational prayer? And then we want to have some conversation about how we would align or perspectives and bring together various epistemic values. Right, the otherworldly value, perhaps even this worldly value of communal prayer, and then this world issue of medical risk. So we'll talk about that, inshallah, together, pending time. In terms of time, I plan to end this by in the next 85 minutes. We're not going to be going more than that, inshallah. So some of this will be speedily done. And because I know you all have to pray Isha, there's an ask for a break, but I'd rather just finish and then everybody just be break and done. So with that, Bismillah, we're going to begin. Is that clear? Wadih? Everybody's okay? So actually the first question I had for you all, and so you can just put this in the Q&A, is how much of these latter two areas, ethics of critical resource allocation and about congregational prayers, were covered by Mufti Zubair yesterday? So if you can tell me that in the chat or the Q&A. Someone's already asked a very lengthy question. Okay. But let's see. So can you respond? in the chat? Did people attend yesterday's session with Mufti Zubair? Did he cover a lot of these last two things? He's covered it in detail. He's covered both those areas in detail. He did cover all on prayer. Okay, so then maybe you guys can educate me, and then we'll talk about it. Well, I don't know. No, well, I don't know what he presented, so it's not for me to cover what he presented. It'd be good to hear what he did present. So, khair, okay. Fine. So let's go ahead, inshallah. So as I said, I see there's several questions coming through. I'm not going to look at these until there's a chance. Okay, I see. All right, so let's move this until there's a moment for break. Okay. So bismillah. Okay, so let's talk a little bit about end-of-life care ethics. I think you all know this already. So this, and if there isn't, I'll pause. We'll have more conversation. But what I'd like to talk about in the first part is sort of relevant theological concepts about healing, right? So a theology of care. And then we're going to talk a little bit about the rulings, right? So as I mentioned, we have to kind of, when you think about Islamic bioethics, and a lot of people use this term, and I think they use it inappropriately. But when you're talking about bioethics and Islamic bioethics, from my perspective, you have to think about not just the law, you have to think about the theology, and not just the theology, you have to think about the ontology. Right, and then you have to think about all these things together. And then you can say here and actually not just law, but then policy, and then in thinking about how a moral vision for this expanding area of biomedicine is going to be addressed by the moral tradition of Islam. Right. So in this, and I mean that specifically. So ontology, what I mean, what is the reality of things, right? We often talk about epistemology, how you know, what the value of something is. But first, well, ontology, right? So there is life after death. Huh? We don't even think about you're dying, right? There's just a transition. So these are things that ontologically, that there's different realities that we're interacting within. And when you talk about end-of-life care ethics, even the idea of end of life is odd, yeah? We might say there are 5 stages of life for Muslims, or that we believe in, not for Muslims, for humanity, right? Prior to ensoulment in the womb, right? There was a life in the womb, life outside of the womb, right? There's a life in the barzakh, right? And then there's a life in the everlasting life. So this mortal living that we have and worried about is just a small piece of those 5 sort of lives of men. So to quote Imam Haddad, in his book, so my point only is that we have to think about the reality first before we start saying what's Islamic law have to say. And then the theology. So how do things happen within these different realities? What are the concepts from our tradition to think about this? And then we can move to the legal rulings. So you see, that's the way we do. Talk about theology first, then we'll go to legal rulings. So let's talk a little bit about theology. And I'm using that term broadly speaking. Some of you who are ulama might say, hey, what theology we're talking about? Is there such a thing as Islamic theology? Are we talking about, the Ghazalian theology? Are we talking about Akbarian notions of theology? And I will not, if you want in the Q&A, we can talk about that. But for this, let's just say for the moment, we're talking about Quranic and Sunnah-based theology, not various theological frameworks that expand beyond that. And so this is more for the literate individual and not the scholar when I'm using that term theology, right? Because scholars want to be specific more than I am going to be right now. So we know the Quran, Allah SWT says in the Quran, he tells us, he's paraphrasing a dua that Ibrahim al-Islam makes about وَإِذَا مَرِضْتُ فَهُوَ يَشْفِينِي, that when I am sick, it is he who cures me. And so the notion just becomes set up, straightly speaking, that Allah subhanahu wa ta'ala is the one that brings about cure. So when we talk about healing, right, we're talking about a notion from moving from a state of illness or experience of illness to a state of health or well-being, right? And one might say we're moving from illness, right, muddled, to a state of afiyah, but they're not, theologically speaking, they're not mutually exclusive. One can have a state of afiyah, of well-being, and be stricken by a diarrheal illness, right? And this is why I said the theology has to think about. So it doesn't mean that when someone is experiencing illness that they are automatically sick. It doesn't mean that they're sick. But, and we can get into that more when we talk about a little bit more in the future. But the idea here is that the Quran tells us Allah subhanahu wa ta'ala is the one who brings about this sense of healing, right? And that he cures me, right? And shifa here is healing, not cure. So that's the translation here, but the idea that's cure. So Allah subhanahu wa ta'ala restores people from a state of being ill or experiencing illness to a state of healing, or maybe perhaps of afiyah, but they're not mutually exclusive. But for our purposes, when we're going to move down to talk about the legal register, you're moving one from a state of being unwell to a state of being well. Allah subhanahu wa ta'ala is the agent that does that. And this is said obviously by Ibrahim alayhi salam, and there are many other places we can think about this. But moving from that notion that Allah subhanahu wa ta'ala is the one who creates sort of healing, then we have this more directly told to us by Rasulullah sallallahu alaihi wasallam in many hadith, in various books of hadith and various sort of formulations. But here's one, for an example, Ya ibadallah, وَتَدَعُوا يَا عِبَادَ اللَّهِ مَا أَنزَلَ اللَّهُ دَاءً إِلَّا أَنزَلَ لَهُ شَفَاءً, or there's another دَاءً دَوَاءً, except in this one, this says except haram, except old age. So the idea here that Rasulullah says in a command form, right, to seek treatment, slaves of Allah, for Allah does not send an illness, but he sends for it as cure. Yeah, so that's the one, shifa, then da'an dawa'an, right? So then that you say maybe cure, that he sends a illness, a disease, right? Da'an dawa'an, and he sends his cure. So both of these hadith have to be reconciled, or there's not just two, there are many, but you get this idea. And depending on which narration is stronger in your view or in the view of ulama, and the one that you want to set up your theology for, either it is moving from a state of illness, right? Again, like the verse, illness to healing, or from a disease, da'an, to dawa'an, to cure. And they're different concepts from our tradition. And most times, and this is the sadness of our state, of our sort of public state of the Muslim Ummah. At times we say, oh, I understand hadith by looking just at the translation, and then we don't take those concepts and put them in the context of all the concepts that relate to that verb in the Arabic within the literature of the Quran, the Sunnah, hadith, right? So I'm just telling you right now, you can say this, the same translation might be put forth with both of those hadith, but they have different meanings. Da'an, dawa'an, huh? And if you have he sends down, he moves to shifa, that's a different meaning, right? So in any case, that's the hadith. So again, the agent is Allah subhanahu wa ta'ala, right? The Quran and the hadith in this case have the same sort of meaning here, but now the addition is that the disease or the state of unwellness perhaps or illness is also being sent down by Allah subhanahu wa ta'ala. Then you have hadith here, so this is another hadith coming in Bukhari here, that there's a long list of people who enter paradise بغير حساب. One of them is a group of individuals who do not rely upon cauterization, rather they put their trust in Allah subhanahu wa ta'ala. And so here, of the gradation of entering paradise without hisab is given to a class of individuals who have decided that they're going to trust Allah subhanahu wa ta'ala completely and not use cauterization, which is a treatment. Even Rasulullah tells you that in a hadith, in other hadith. It's a treatment for illness, for a disease. Huh? And he says in a hadith that he doesn't prefer cauterization. Nonetheless, the idea is that you leave off man's or human sort of intervention and leave yourself to the will of Allah subhanahu wa ta'ala. Now, there are many scholars who have talked about tawakkul, what this means, does that mean, and you'll see in the legal register will talk about that. But just that's the idea that there are hadith, and now you have to sort of say, how do we reconcile these two hadith? And the scholars have done that for you. But the theology of healing is Allah subhanahu wa ta'ala is in charge of one state, he's in charge of the other state, he has divine control of both states, and moving from one state to another, illness to wellness, disease state to healing state, is all in the control of Allah subhanahu wa ta'ala. And then the Rasulullah explains that there is some daraja of individuals who will get higher grade for just trusting in Allah subhanahu wa ta'ala, that you're actually directly saying, I'm entrusting you, Allah subhanahu wa ta'ala, and not the things that you've given us, that means the asbab. So the scholars have to deliberate and say, how to reconcile these two things. The command verb is used, tadawu, and does that mean we should do this? And that the other hadith is nasq because of it? I mean, there's many conversations. But what is also known here in the points of deliberation is that there's certainty about cure. Where is certainty in cure? Certainty in cure is not in the Tylenol that you take necessarily, but the fact that Allah subhanahu wa ta'ala might give that Tylenol the quwwah to remove your headache. So the certainty is always with Allah subhanahu wa ta'ala epistemic to bring about cure, not with any of the asbab. So بغير حساب, بدون asbab, he can bring about cure. And then medicine, the medicine that we're talking about today is probabilistic knowledge. It can be of various grades. So we classically talk about, medicine that is harmful, right? Meaning that you take something and it brings more harm than good. That is equivocal. That is possibly a benefit, possibly of not. And then there's medicine that has a dominant probability to help, right? So غلبة الظن, ظن الغالب, ظن الراجح. So in any case, there's many different epistemic registers applied to medicine. And for us, at least, alhamdulillah, those who are from the clinical background, you know that you can sort of go through this and say that the grades of evidence for the benefit of medicine, right, throughout. So I know there are many things in chat. I want to go on, and then I'll give you a moment to pause. Just hold on. So how this gets translated into the moral status and care classically within the Sunni schools is that because there are two hadith of both of similar grade, and they're not just two, they're many, right? And then we have actions of the Sahaba, right? So for example, this notion that, look, yeah, if Rasulullah said that you should seek medical treatment, tadawu, and how come a Sahabi like Abu Bakr or Umar or even himself, Rasulullah doesn't seek medical treatment all the time? So you can't say that that is the higher notion because the Sahaba that were around him didn't do it all the time. So then we have to not say this is a command, because would you say that if the Sahaba wouldn't follow a command of Rasulullah? Someone really wants to talk. Hold on one second. Okay, let me see the chat. All right, there's, we can talk about this later. I'm sticking to this. We can big pharma, all these things we'll talk about later. All right. So in any case, the general ruling becomes that it is permissible, it is in this realm of mubah, it is jaiz to seek medical treatment, and that is what the Sunni schools classically uphold. The Shafi school with their notion that hadith and the statements of the hadith have a specific grade within them of evidence of dala'il, that tadawu is used as a recommendation because this is what the words used were a command form. So it's mandub. So the interesting thing is that seeking medical treatment might not be one that you get rewarded for. In most of the schools here, they say there's some reward. Now that's general ruling, not contextual. The question then becomes, is it fardh or wajib to seek medical treatment? And there will be a case where they say, yes, there is, and I'll tell you that in a moment. But you'll notice that one of the Sunni schools, the Hanbali school, says, no, it is never obligated. Rather for them is that you should have just trust in Allah subhanahu wa ta'ala, tawakkul. If you have the inner fortitude, the spiritual certitude, then you should always rely on Allah subhanahu wa ta'ala only, or just. But they don't say that it violates tawakkul, right? So I mean, the idea that if you were to take medical treatment, does that mean you're not trusting Allah subhanahu wa ta'ala? No, unless you believe theologically that the medicine has healing, Allah doesn't have you put the quwwah within it to heal. If you do that, then that is against tawakkul. And that is also objectionable from your aqidah standpoint. Otherwise, it's fine. So that's how they resolve the question. Now, as I said, the real issue here becomes, when is it obligated? So in classical books, they'll give you several examples. But one of the most common examples is of the individual who has a severe cut on his body, and he's bleeding, and that person said, is it obligatory upon that person to seek medical treatment, meaning that they tie off or put a bandage on them, or they cauterize that wound, or whatever else it might be, so that they're not going to bleed? And the three schools here say, yes, it is. It's fardh. I'll tell you about the Hanafi business in a second, but they say it's fardh, it's wajib, or it can be wajib. And they use the analogy that, look, there is a certain, if you're going to tie cauterization, the cauterizer will tie some sort of tourniquet on that wound, they're going to stop from bleeding. So if they had not done that, what would be the result? The result is sure that the person will die, because the blood will leave their body, then they will die. So you have a certain notion that they're going to die, and the cauterization or the tourniquet will certainly stop the bleeding, so there's certainty there. And because there's two certainties here, then it's obligatory. It becomes certain, meaning it becomes wajib for you to seek. that you get that treatment. Otherwise, what you're doing is you're going to allow yourself to kill yourself. That's what you're doing by analogy. And Allah subhanahu wa ta'ala, that do not by your own hands put yourselves into perdition or to kill yourselves, and therefore that's haram. Rasulullah has made hadith about this as well, so therefore we don't want to use that analogy. The analogy is the qiyas here is that a person is going to allow himself to die. Okay, now that's one level is obligatory, but now look, the Hanafis are very interesting here because, we have, the Hanafis have more than 5 gradations of moral status, right? So there's maqruh, tahrimi, tanzihi, right? There's wajib and fard. And so the ocean here is, so from when I say in the other schools that it's obligatory, that means if you don't do it, you're sinful. It's obligatory to pray, it's wajib to pray. You don't pray, you're sinning. Hanafis here, in this case of leaving medical treatment, say you're not sinning, even if it's certain that you're not sinning. Okay? All right, okay. So the point here, again, as I said, is that there's a certainty notion here about the certainty of the result, if you don't get medical treatment, and certainty of what the medical treatment will offer. Therefore, obligation exists if the effectiveness of treatment to cure, in this case, or remove illness-related harms. Remember the 2 hadith here, right? You have the dawa'an or you have shifa'an. If those things are happening, it's highly probable. In this case, not just certain, 100% yaqini, but rather there's a ghalabat al-dhann, that there is more than 51% gradation that you're going to be restored, then it might become obligatory because you will die otherwise. Okay. So I'll say this, then we'll stop for a second. 2 slides and we'll stop. Okay. So that's classic. Now I'll say this, Jafri school and what I've read, they have this sort of obligation to seek medical treatment when certain as well. I think that the view here is that they're much more on the not just permissible, but you should seek medical treatment, and then it becomes obligatory. All right, so now take a modern council. It's not modern anymore. I mean, it's 1992, but you have these collective ijtihad councils, and they sort of speak about what is obligatory to seek medical care. And now when you talk about this ruling, everybody cites this ruling from the Fiqh Academy in Jeddah, when they say, okay, we're going to expand. Basically, the question was, well, the class of scholars were talking about medicine at that time, right? Now medicine's different. So what do we think about the obligation of seeking medical treatment? And they say it's obligatory when neglect might result in death. So this is the same as the classical ruling, meaning that the treatment is life-saving, or that the leaving off the treatment will lead to a loss of an organ or severe disability. So now you're causing yourself harm, although it's not death, but other credible harm, functional disability, right? So now they raise that, sort of expand the zone of obligation. And then they also say if the illness is going to harm others, right? It's contagious and it's going to harm other people. So there's a treatment that you can take, but you just refuse to take it, and now you cause others harm. So the public health notion, we're talking about pandemics, comes in here. So this is their ruling, and you'll see that this is now quoted by fuqaha, muftis, and Shura Council all the time, because they believe this is now how medicine works today. So we should think about this. But the classical rulings are still in the books, they're not obviously, they still apply. So they expand the zone. Now, what does this mean for us practically? So the moral status, right, the Islamic ethical legal status in this case of seeking medical care is that there's a very small zone of obligation. There's a large zone of mubah, and there's a small zone of don't take it, right? So we're really interested in the mubahness of it, right? So it provides variability, that there are many different courses of action one can take because it's permissible. It's not sinful to leave off, right? You might say it's permissible, not just permissible, it might be mandub at times. So you can do a lot of things that are permissible within the context of seeking medical treatment. And there's only a few things you have to worry about. So there's a larger zone of permissibility. It leaves room for personal values beyond the religious. So if the religious says, okay, yeah, most of the time, 90% of the time, you can seek medical treatment, then you can say, well, what kind of treatment do I want, right? There's 15 options. I can get antibiotics for appendicitis. I can have surgery. I can do this. I can do that. So it leaves for a lot of ability to make choices about what sorts of treatment, how you get treatment, as long as they're not going to leave you dead or that they're harmful to your body. this perception that is often bandied about in public arenas, public media, about religious individuals want everything, right? Let's do everything all the time. This is not the case from an Islamic perspective, because the obligation is normally circumscribed, meaning you're not sinful if you leave off. So actually it's the opposite. We don't condemn individuals who say, I don't want to get medical treatment. Okay, so let me stop there and I'll take some Q&A here. Hold on. Okay, so I don't know if you can see my screen, but there's a question. This question is about the flu and stuff and 5G. I don't know, this is not about this right now. Shouldn't Muslims seek naturopathic cures? Okay, I'll answer this in a second. All right, okay. So let's look at this first one. You know, naturopathic, this is obviously this conversation here. We're not going to belabor this point, but as I said to you, Islamic law has this notion of epistemology embedded within when you're making rulemaking, right? When you're making legislating fiqh. So they said certainty, dominant probability. So they're using numbers, right? Or a qualitative judgment about numbers. So is now, if you say, okay, well, look, I'm going to take zinc for COVID-19, and I'm going to use 10 milligrams of zinc a day versus 50. Tell me what is the probability of that helping you with COVID-19? Do you have any data? The answer would be no. There's no data, right? Or there is data of poor quality. So for scientists, we can say, okay, well then why would the scholars say it's obligatory to do that? If you don't have data, you might say, well, the whole system is set up so that naturopathic cures don't get data, or people say there's experiential data for hundreds of thousands of years. Fine, you can make those arguments, but let's bring forth the data. If there's no data, then the highest gradation you can get is permissible, but we can't say it's not permissible. And if there are any data that says harm, chloroquine they're talking about, there's this data, I think today, study came out, or yesterday, in New England Journal of Medicine showing harms of taking chloroquine for COVID-19. Well, the Islamic tradition says, darar mafasid, awla, or another qaida muqaddama ala jalb al-masalih, that you should be removing harms, right? La darar wa la dirar. So if there's known harm, credible known harm, then you should say stay away. And the classic fuqaha and as well as the modern contemporary ones say the same thing. So if there is a notion or a quantifiable notion of harm occurring, then you should stay away from those things. Now, they might not say you're sinful, but that's how it works. So I don't think there's an Islamic mandate to do anything except for be very evidence-based and driven towards removing harms where you can. Okay, is taking vaccines halal? I don't know what that means. I'm not a mufti to tell you it was halal or haram. Sure, it's halal unless it has haram ingredients. I don't. If there's another question you want to ask, we can talk about that. But in the context of what I'm talking about, vaccines aren't coming up here, right? They're not life-saving necessarily, but there might be some that you say they are life-saving at specific times for individuals, right? So people who are told to take flu vaccines might have their own makeup where they're at high risk in a certain population, and then if the dominant probability is that they will get sick because they're not taking a vaccine, perhaps they should. So you can ask Mufti for that, perhaps. But anyway, all right. So there's a hand up. I already answered this one. Yeah, so I think all these are very interesting questions. I'd like to stick on topic, right? I mean, we can have Q&A, but I'm going to go through three things. And if I start sort of pontificating on a lot of your questions, I'm not saying they're not important, but then we won't get to my subject matter. So if you have time at the end, I can address things that are not directly related. So the question about AMAF said about the classical fixed schools classification treatment directly available to today's evidence base. Yes, that's the answer. Yes, they are. because even classical schools, Ghazali, Ibn Taymiyyah, others talk about 3 or 4 or 5 categories of medicine. Medicine that is known to produce harm, medicine that's known to produce benefit, medicine that you don't know harmful or beneficial, medicine that has an ability to help, but not as it's not known, but it can, right? Or it is likely to, and medicine that's likely to harm more than it's beneficial. So those 5 categories exist. This was the same idea. There's no change now. And so this epistemic grade 2 medicine exists in the classical times, exists now. All right, so let's move on now. So we're going to talk about end of life. These are some papers just for the screen that I've had the ability to write with colleagues of mine. And we're going to delve into this for a second. So we started off talking about the moral status of seeking medical care. We're going to move to the other end in a moment, and this is the junctional slide to do that. So before I do that, I'll just say, and we can talk about this more, that if we have time in the Q&A, that we certainly, in all our lives, we say that Rasulullah's example is the example we should emulate, as he was as a father, as a husband, as a leader, as an educator, as everything. And so here we have the example of Rasulullah's last days in our hadith collections and our seerah. And so this is the ibrah for us to think about the most blessed way to deal with the fact that one's approaching their end of life in this life, right? How to face mortality. And I think it's a treasure trove for us who are physicians, for us who are da'is, for us who are, chaplains, to think about how we should, what the comportment we should have to face the end of one's life, in a responsible way, but also one that is dignified. Right. So for us, the death with dignity would be this example from Rasulullah sallallahu alaihi wasallam, and the notion of a good death would be again here. So I want to share a couple of things for you to think about. But again, I'm trying to give you a sense that when you move to fiqh, because everyone wants to jump to law, you must. In the first instance, I was talking about theology and ontology. Now we have to think about, well, how does the example of the exemplar for our tradition match up with what we're going to talk about in end of life? Right, the fiqh doesn't have to fit necessarily the seerah here, but the seerah is an indicant to what the fiqh should be. Okay, so here we see that Rasulullah. These are this, inshallah, make dua that I have time to write this up in a more significant way. It's been 2.5 years that the paper's pending of mine, but in any case, you see near the end of his life, Rasulullah goes to the Untitled Chapter with his servant, and he goes and there's some communication that's happening. The servant overhears some of this communication. He hears the term al-fiqh being said by Rasulullah, and then when he comes back, there's various ways, narrations of how this happens. When he comes back, Rasulullah either says this to him or tells him directly, but says this to him in a third person sort of way. What would you say about an individual who's given the choice to live everlasting life or to be with the highest companion, meaning Allah subhanahu wa ta'ala? And what would you choose, or what would you say if a companion chose that? Right? So he was sort of giving a shout out that he was given this choice, and then he chose al-fiqh al-a'la, and that's why he heard him sing al-fiqh al-a'la. Right? This also happens again in a different way, where he hear the words him saying al-fiqh al-a'la on when his head is in the lap of Aisha radiallahu anha, our mother. Again, choosing al-fiqh al-a'la over this life. So when his time was coming, he had chosen his time in a sense, right? That he was given a choice, and he chose to be with Allah subhanahu wa ta'ala, and to meet death in that way. So after that happens, you see that he goes to the minbar, he tries to lead salah, he gets very sick, right? His last sickness is very severe. We hear about the headaches, he has fevers, people bring water skins to give him baths to reduce the fever. He's unable to stand for some of the salah. He comes out, he comes out one time, people think he's gotten better. He comes out to give a sermon. And he sort of says, at one point he gets up and he says, he tells the gathering around him, do I owe anybody anything? Please take it from me. Do I owe anybody anything? And the Sahaba all are silent. And then a man comes from the end. He says, oh yeah, Rasulullah, you owe me something. Right? So he was asking about money, and whatever he gave, whatever he had to give, he gave back. But then he says, what was this? He said, well, when you were riding a camel, and I was leading the camel, you went to strike the camel, and you struck me and not the camel. So he starts coming up to Rasulullah. So in various narrations at one time, Umar radiallahu anhu and Abu Bakr get up and they're going to push this man back because they know what this means. This means that the person wants retribution, right? And so Rasulullah uncovers his back and he turns around and the Sahaba are livid that some man has this ability, this sort of desire, and he's going to do that. So when he uncovers his back, the Sahabi kisses the seal of the prophets, right? And that's the retribution in the sort of sense that he just wanted to see the back of the Rasul. Because Rasul says, no, he says to the Sahaba, no, he has a right and I must give everybody their right. So in any case, the idea of setting affairs of your world, of this world, giving people back what you owe, and all these things are taken care of and should be taken care of. May Allah give us tawfiq to do so when we're lucid, have the capacity to do so before we depart this world. I mentioned this in other sort of webinars and workshops where then now, really near the end, he's at times becomes conscious and unconscious in the house of Aisha radiallahu anha. At one time, he's semi-conscious, and they bring in medicine, they try to put it in his mouth, and he moves away, but then they put it in his mouth, and they force it sort of in, and he becomes conscious again, and sort of asks, why did you do that? And they say, well, look, we know medicine is not tasty, so when you're pushing your mouth away, we thought you were doing that because you don't like the medicine, the taste of medicine. And Rasulullah says to them, well, why don't you take this medicine, taste this medicine, except for, I think it was Ibn Abbas or someone else, he says, except for that person, didn't force me. Again, the idea was he had already accepted death and they were putting in medicine. In his mind, it might have been futile. I don't want this medicine. And so we shouldn't, force family members or to take things that they don't want to. And then really near the end now, one of the things that Aisha says, she says, I had this amazing status, this maqam, that at the end, the last moments of Rasulullah in this life, that our saliva was mixing. And she's speaking about the fact that her brother, I believe, comes in and Rasulullah sees him and he's now can't speak so much. So by his eyes on her lap, she can tell he wants the siwak. And so he wants the siwak. And so she thinks he wants the siwak. So she takes the siwak and starts sort of moistening it with her mouth, with her teeth in her mouth, and then puts it into the mouth of Rasulullah so that he might be able to clean his teeth, and he dies in that state. So why would Rasulullah want to clean his teeth? Because the veils of this world and the other life are being lifted. And what do you think he's seeing? Right? You're going to be in the company of angels. We know the hadith tell us that the person who dies and is a mu'min, angels, they're beautiful, come and show you this cloth to wrap you in that is beautiful. So all right, so if you're in this amazing group, and you're seeing these sorts of things, wouldn't you want to prepare for being in a good state with them? Now, there's many ibras. This is from Aasim Padela telling you this, but in any case, you can see that this notion of decorum, dignity, even at this departure from this world, is one that's important in the actions of Rasulullah in the end of his life. So I say that because now we're going to go back to the fiqh, right? And so everybody wants to talk about the fiqh, but we forgot about the adab, we forgot about other things. So here, let's talk about the fiqh for a second. And colleagues of mine, and students of mine, and we did this sort of review of the notion of when it's permissible to withdraw and withhold this medical treatment from the perspective of juridical councils and prominent fuqaha. I put this slide up for you to think about for a moment. We're going to talk about some of these, but and we're going to talk about what the research shows, generally speaking. But you'll see here that there is a divergence of opinion and different things said by different councils about when it's permissible to withdraw and withhold. But that fiqh is dependent upon when you also believe it is mandatory or obligatory to seek. So, for example, and it's also mandatory. It's also dependent upon what the construction of medicine is in your society. So, if you look here at the Saudi fatwa for Khomeini, right? In Saudi, there's a very paternalistic type of medicine, right? So they actually address their fatwa for physicians, and they say 3 physicians can certify these 3 things, and people can withdraw life support without talking. They can withhold life support without talking to the family. The family has a diminished role. Now, those of you who are in the UK, Canada, here in the United States, might say this is sort of objectionable from the adab, from the practical ethics of physicians here, from our code of conduct or whatever you might say, but this is not how necessarily they thought about their picture of medicine in Saudi. So they say that 3 things, right? 3 conditions: illness is unresponsive to treatment and death is certain. So at the last moments when the person's not recovering, that the patient is in a state of mental inactivity or has untreatable brain damage. Okay, or they say resuscitation would be ineffective. So those are the things they say here. We'll talk about these in a moment. But if you think about withdrawing, so now you have a person on a ventilator or on some sort of supportive blood pressure medication, they say, well, if the result is the person is going to lose perceptive capacity, they can't interact with the world around them, then you can withdraw life support. Again, speaking directly to physicians or to families here. And now if they're vent dependent in Darul Zaqariya and South Africa, they say if you're vent dependent, then you can also withdraw. It's not obligatory for you to continue. You'll see that in Kuwait, this is now a juridical council of medical fiqh council. These here are mostly fiqh councils. This one involves physicians, so they're actually issuing a qarar, and they say if it's useless, I don't know what that really means, or again, use is futile if the person's reached brain death. And then another medical fiqh council here with physicians and jurists, they say brain death. Imana is here just to say this is a non-jurist body, but they have they even move beyond it, terminally ill or persistent vegetative state. So this is not actionable in my view right now, but in any case, they have a different view. So you see that there is some differences of the terms that they're using. Now, there is in this paper, and if you want, we can email a lot of it, they'll send it to you. You can Google it. But there's a paper we did on a fatwa review, again, of juridical councils and prominent jurists, and you'll see that they use these sorts of terms, right? Withdrawing and withholding life-sustaining treatment is permissible. So when care is useless or futile, they use these sorts of terms. And what we understand from that is that the medical treatment is inefficacious, right? That you have a declining possibility of it removing illness-related harms or being curative. Therefore, the harms are outweighing the benefits. Right? That there's no dominant probability that this will bring about a restorative change. And the second sort of idea and thematically is that the patient is in a state of mental inactivity or brain damage. And what this might mean would be that for clinicians, that this person is going to be permanently, in some minimally conscious state or is not expected to recover. So physiological life perhaps is not just sufficient, but there needs to be a qualitative life on top of that, right? A personhood on top of that. Again, this is from me in our analysis, not what the terms that the fuqaha use. Then they say a patient is terminal, meaning what? And it's unclear when they're using that term, they mean someone who's got terminal illness, right? So as a physician, I can say anybody who's got cancer stage 4, whatever their physical status is, that is a terminal diagnosis. They're going to die at some point, right? When we talk about palliative care and hospice care, you say they have 6 months of predictive life of life. So they're terminal. Does that mean that anything at that time it can be withdrawn and withheld? I think perhaps this is what they're getting at. When you're that, and then brain death, we just talked about this notion of mental inactivity and brain damage, but they say specifically brain death here, which is a misnomer, but neurological criteria for death are met, then you can withdraw and withhold. So now let's kind of take this to the COVID notion, right? So what does it mean when you talk about COVID-19? You might have seen these on social media, that let's talk about permissibility of foregoing life-sustaining treatment. Well, is the treatment that's being proposed life-saving? Because I shared with you that both the classical and the contemporary scholars have said that if there's a certainty of a life-saving treatment, right, and without it you will die, then you must apply that treatment religiously. Now, when I say that you must apply, some people misunderstand this. Yes, scholars will say you should apply, but it doesn't mean that you can decide not to. They would just say that they wager that there is sinfulness in it. But there are many things people do that are sinful. And no one forces you to be on a respirator or something else, right? And they can't force you. So this is a religious advice from the best of their understanding of the fiqh. I'm just saying that because some people say, well, does that mean that a policymaker must always do this? Well, or an individual will, we're talking about measures of sin here, not about, some law telling you that you'll be put in jail if you don't do it or something like this. Although one might say sin is greater than jail time, right? As Yusuf al-Islam said, right? Rabbi right? So subhanAllah, I can't remember the verse, but he says that if put me in sijin, that's better to me than that. So in any case, there's the idea. So is treatment certain to be life-saving? Is it certainly or highly probable? No. If that's the case, then it's permissible to forego all that package of treatment. right? And if yes, then it's impermissible. It's pretty simple. It's just two actions here. In the context of COVID-19, we know there's no curative treatment, rather it's all supportive. And when you get to a certain stage where you need ICU care or ventilation, right, that is a very poor prognosis. Data from countries suggest at best, you have a 50% chance, at best, of surviving that illness when it gets to that stage. So therefore, there's no certainty, meaning here greater than 51%, or high, higher than that. So it's permissible to forego treatment in most cases. Now, I will say that this data is changing constantly, right? So medical care in China is different than in South Africa, than South Korea, than different than Italy, than Spain, than the United States. So my own hospital here has a higher potential rate of getting off the ventilator and getting, 30-day mortality is higher than, I think it's 10% or something like that, very low in other countries. So this, as we get more experience with treating this disease, we might get better. But at this point, there's no one near 50% chance of getting out or living in 30 days after you get intubated with COVID-19, for COVID-19. Okay, so now the question becomes, as a patient or a family member, is it permissible to withdraw life support? So you've already been intubated from the ER, now what do we do? Well, then the question becomes, in this package of treatment that you're receiving in high intensity of care, are the chances of recovery to a conscious state probable, greater than 50%, right? Meaning that you can, because the withdrawal idea was, well, if you have a depressed mental activity or brain death state, is permissible withdrawal. Well, if the science is telling you you can't get here, there'll be something less than that, then it's permissible withdrawal. But if science tells you, or the clinical data is telling you that you can, then perhaps you should continue. So it's permissible to continue, it's permissible withdrawal. Okay? Does a treatment outweigh harm? So I mentioned to you here that, if there are declining chances of recovery, then, harms might accrue that are significant. Being in the hospital can be to some people a harm. Being dependent upon others to bathe, eat, drink can be to individuals a harm. This notion of hurma and karama is somewhat dependent on the individual's own view of what that quality of life is. But it is harm, right? It is a credible harm within the Sharia to think about these things. So if the treatment harms outweigh benefits, then perhaps no, you should, right? Perhaps then you should, it's permissible to withdraw as a family member or a patient. So the idea here is harms and benefits have to be weighed against individuals' notions of what those are, what they aren't. And one might say that being in the ICU can be just a harm itself, and I don't want to be there. Okay, and I'm going to have a break in a second. So now this is from that paper I mentioned to you where we looked at fuqaha, right? These are some fuqaha councils. And you'll see they use different types of terms for withdrawal versus withholding. Withdrawal, you have useless or futile care, brain death, inability. This is the only one that we ever saw that said that you don't have access to pay for that care. No for cure. And they're different. So oftentimes you'll see people say, oh, it's futile, or doctors say it's futile, but there are different notions of futility here. One might say someone will die imminently. One is sort of a qualitative life, right? That this is not a qualitatively worth life, or physiological qualitative here. When you get to withholding, withholding seems to be imminent demise or lethal condition. But there are different terms again used here: terminally ill, patients unfit for resuscitation. So I'm telling you that there's a lot of conceptual lack of clarity, and I would say lack of sort of robustness of the concepts that are being deployed here. So what does this mean for us as physicians or clinicians or bioethicists? Well, I would say, and I can say this definitively, that withholding and withdrawing are different acts. They have different contexts, and they are experienced differently by physicians and patients and families. And one can make a credible argument from the tradition that they are not the same morally either. That the obligations are different to say, I don't want to put someone on versus I'm going to withdraw something, okay? But however, the fuqaha and these juridical councils have not made this distinction very clear. Only this one group in Madrasa Namiya sort of said that it depends on how you think about it as an act of omission or act of commission, and what's permissible. And I already shared with you that these rulings are somewhat, unclear about futility. Is this physiological futility or practical? Is this for a specific symptom like pain, right? Or is it for the overall trajectory of one's illness? Because we know, there's a declining curve all the time when we talk about palliative care and withdrawing life support. And then they don't define life-sustaining treatment. Do you mean the whole package, which can be construed, or do you mean specifically the ventilators? Some are just talking about ventilators, right? Not the idea to support the blood pressure or antibiotics or other things. There's a classical debate whether feeding tubes or IV nutrition is part of this package of care you can withhold, withdraw, or you cannot. And easily when people talk, about making their end-of-life care sort of advanced care planning, these fatwa are not easily translatable to post forms, which in the United States is physician order for life-sustaining treatment, or DNR forms, do not resuscitate forms. I mean, this is not like a cookie cutter approach. You have to sort of think about what they're saying, which scholar you want to follow, and then work that into your own specific post or DNR form. Okay, so I want to stop here and take some Q&A. Oh, look at this Q&A, Joel. Can you talk about DNR for elderly Muslim patients and having this combination of setting affairs in order? So I'm not sure, what do you mean about, what would you like me to do about that? Let me see, is there a way to let you speak? I'll clarify that. So Imad, what do you mean? Okay, what do you mean, Ahmad?
Assalamu alaikum, sir. I just wanted to ask about having those conversations and whether it's when we see our affairs in order, and if that's a thing.
If that's a thing, you mean to have the conversation with them? I mean, I think so. Let me answer this point. That Muslim physicians serve various capacities and different roles, right? So in the context of the community, you are seen as maybe the medical expert or the bioethics expert, and so asking you for advice. So I think that you should definitely be thinking about talking about. I say we should be thinking about, what our goals of care are, whether or not you're of a certain age, particularly in this context of COVID-19, to think about these things. We should all be thinking about that, right? People are intubated, God, as far as people in our family, the same thing, right? We should be talking about this. Yes, I think we should be having this conversation about saying our affairs, because this is not just a Muslim doctor thing, it's a Muslim thing. You're giving advice to people, and you can say, look, this is Allah, this, we should be doing this as well. You don't want to have Allah subhanahu wa ta'ala, and there's many hadith, and if you look at these hadith, Allah subhanahu wa ta'ala, there's it says that Allah will not look to people. For example, Allah will look to brothers and give them, right? They will not have to do Eid if they are having animosity between them. And that's not the exact wording of the hadith, but my point is there are many hadith like this that talk about Allah subhanahu wa ta'ala la yanzuru alayhim, right? Wa la yuzakkihim, and He will purify them. So we should be using these hadith as a irshad to tell people to set their own affairs in order. So that's my response to you, Matt. And as a physician, Muslim physician, I think it's even more important. Life, can you take right? Yeah. So we can. I mean, I think my talk here is about ethics, but there are certainly many we should like how the that they're death, and there are many jewels for us to take from them. Okay, please express a big pharma and fake science. Yeah. Okay. If we have time, we'll talk about big pharma. I don't know. It seems like there's a question that you want to say. You want to talk about pharma, but this talk isn't about pharma. Maybe we should actually talk about pharma. Anyway, so those are the questions here. Some other people raised hands, so let me see how that happens. And when you look at patients who have met brain death criteria, there's a certain natural history of these patients. And the natural history is that usually have cardiac arrest. Now, it might not be tomorrow, and not be the day after, but there was a large study done by, I think, 𝐁𝐚𝐥𝐚𝐿 that showed within weeks or less than a week that people will have cardiac arrest, right? Even if they're maximally supported medically otherwise. So that's the natural sort of history of people who have met the knowledgeable criteria for death if it's diagnosed properly. I say that because when you think about brain death rulings in the juridical council, all over the place, contrary to what people think, that they are all over the place. They use different terms, and they don't signify exactly what they mean at times. These are now over 20 years old, so there are new councils that have talked about it. They analyze brain death either as not legal death or as this category that's unstable life, a state between death and between death and life, so a dying state. Or others say no, it satisfies the legal criteria for death in Islam. All right. Here's two example verdicts from prominent juridical councils. So the Academy of the OIC says brain death is equivalent to legal death. They specifically say in Arabic, this is the English translation, all vital functions of the brain cease irreversibly and the brain has started to degenerate. When that happens, someone can be declared dead by Islam, by Islamic law. While the Islamic Organization for Medical Sciences, which actually had some of the same fuqaha and the same, and this was done, I think, just a year after, they say brain death is not death Islamically, in Islamic law, but it is a category of unstable life. Therefore, you can draw life support. Rather, you must declare someone dead when the heart has stopped. So these are two actionable, different views from prominent fuqaha around brain death. So someone's raised a hand. I will have a pause in a moment, and I'll go through the questions, okay? So, yeah, there's just two more slides. So I'm saying this because both of these things are, again, as you remind the literature, that there's the physicians at least, there's a little lack of clarity of what they mean, what fuqaha mean, right? So what do you mean irreversibly? What are the vital functions of the brain? Is it brain reflexes? Is it something else? What do you mean by the brain degenerating? No one looks into whether the brain is degenerated, right? And when they say some rulings of the unstable life, well, what are the different rulings? If withdrawal is permitted, what about feeding tubes? What about a patient who's pregnant and she, God forbid, suffers a brain injury, is now considered to be neurologically dead? Do we keep her supported so that her fetus might reach an age of viability? Those things are not captured within these rulings. Moving forward, and I think that one of the things we're thinking about, as I said, we went from theology in this case, or then seerah in this case specifically, to legal rulings. So now let's talk a little bit about theology. We have our life, and I'll say this, life is of instrumental value, not ultimate. Life here is of instrumental value, not ultimate. Meaning it is an instrument towards a goal and an end. For those of you who talk a lot about maqasid, right? Maqasid is in vogue in many circles, technical circles. What we're talking about, right? That there are human interests that serve certain purposes. That the law serves a certain purpose. There's an axiology of values here. So, hifz hayat, right? Hifz nafs, which are maqasid, protection of life, whichever one you want to talk about, because sometimes people say protection of life is hifz hayat in the Arabic. Sometimes people say hifz nafs means the same thing. Others have said, no, nafs here means consciousness. So something that means consciousness. That means personhood and not just life. Okay? So there's a debate there within scholars as well. But it's an instrumental value. Why do we want life and why do we want consciousness, whichever instrument you want to take? It's because of these verses that life is created for worship. Or here, that worship your Lord until death comes to you. So this is the idea here that there is a value. The purpose here in this life is for an afterlife that has greater value. And therefore, when you can affect good works in this life, then you should ask for extension of life. And this specifically, by those laws. So there are narrations here again, where someone asks, can I make a dua to Allah subhanahu wa ta'ala? Again, direct message to Allah. I need us to die because of something that was befalling them. And he says, none of you should make a request for death, For when one of you dies, he ceases to cease, right? You shouldn't do that. And then he's asked again, and generously says, well, none of you should make a request for death because of the trouble that you're involved with. Some people say this Sahabi had some medical issue. But there's no other help to it than saying, oh God, keep me alive as long as there is goodness and life for me. Bring death to me when there's goodness and death for me. And the reason I underline this is because in both states there's khair. So you're asking Allah subhanahu wa ta'ala, where there's khair. If there's khair for me to live, meaning I can do good works to affect my afterlife positively, give me life. But bring death to me, not I ask for death, let me die, but bring death to me, O Allah, because you're the one who brings death when there's goodness in death. So death can be good, perhaps because you're in certain pain or to some other issue, right? And then you're asking Allah subhanahu wa ta'ala, who has ultimate control over your livingness and your deadness, so to speak, and you make this dua. And this is a dua that that we know. It's not like some dua, it's a real dua given to us by Rasulullah. So there might be khayr in death. But from this is for our conversation, and when you're thinking about life, it's an instrumental value, not one of ultimate value, not at all costs, not under all circumstances. That is why it's important to have conversations with our own families and our patients and those who we advise about, again, thinking about goals of care, advanced planning. We want to make this life the best life for our akhirah, not just because we're here. All right. I'm going to leave the slide. There's another paper I mentioned here about the idea of mukallaf status as the quality of life marker. We can talk about that in the Q&A, but that's what one I use. That some fuqaha say is also fine, but in any case, it ties back to the idea of affecting good works. Okay, so I'm going to stop here and take Q&A for a second. I apologize if I haven't gotten to you. I don't use too much. I don't know how well through. Okay. So there's a question about the research. I want to pause that question about big pharma. Okay, so someone really wants me to talk about big pharma. Let me just sort of say that there is nothing in my talk here today that's about big pharma. If there is time, we can talk about big pharma. We can open up lines. We can have a conversation about big pharma. But my intention, the learning objectives for this class today are not about big pharma, and I don't intend to go there unless we have extra time. So I hope that answers your question. If a patient is coma due to a condition with poor prognosis or there's no cure for the condition, is it permissible for the physician to withhold treatment? So it depends on the context here, right? So saying that the physician is operating under a jurisdiction, right? So now, for example, in the United States, can I unilaterally withhold life support? Perhaps. I do that every day in the ER when someone has come in and they've had 20 minutes of CPR in the field. They're technically dead, but they're not legally dead unless I say they're dead, and I can say they're dead, and I'm not going to do anything. So I can do that in that context, right? I say I'm withholding doing more CPR, doing epinephrine, doing whatever else it is because there's no possible good outcome here. So yes, we can, right? But there might be a context where you're not. So if there's a patient in the ICU who is in minimally conscious state, or because we're not talking about coma is a layperson term, medically minimally conscious state, and I say, hey, you know what? I don't think that bed's not good for this patient. Let me just unplug, the machine through all life support so I can give it to the next patient living, who might need it from the ER. Now you can't do that legally without having a conversation with the family, without allowing them, right? You can't do that unless there's multiple, maybe in Saudi 3 physicians certified, then perhaps, but not in the United States. I can't do that. Can't make you allow decisions for family member for a person in the ICU. So it depends on context. I hope that's my question. So someone asked a question here from a personal nature that that they had a daughter who was disabled and she was ventilated, and physicians sort of felt that this was not a quality of life, and so this was a problem for them. So let me say this is actually not a problem for them. This is a problem all the time, because what medicine is, or what these terms that we're using, not quality, is not it's a subjective term. We'll get to this better in the research allocation bit in a second, but it's subjective. Right? And so I can advise, I don't think this is a life worth living, but who am I to decide for you? I can only advise, and I can't force necessarily. Similarly, if you're a parent and you have a daughter, or you're a parent and you have a child, or you're a son and you have a parent in the ICU, how am I to judge what their quality of life is? What does that mean, really? Unless you had a specific conversation about they don't want to live like this, or they say, I don't want to live like this, right? Or this is too much for me, right? May Allah make it easy. I never had that situation, but that's the point. These are not scientifically based sort of here's them, right? They're qualitative and subjective judgments, and so there's always going to be disagreement, or not always. There is a high likelihood of disagreement with people about these things. And when you make fatwas and you make policies and you make rulings, that you have to know this. And I think sometimes people don't recognize that. So let me answer it that way. Okay, there's a bunch of chat stuff. I'm not going to look at the chat until the end. I looked at the Q&A now. So we're going to kind of move to the second part of the talk. We have only an hour or 45 minutes left. So we're going to the second part of the talk, and then we're going to have a conversation. So that was my didactic portion. This is going to be a little bit about conversation on the lines in a minute. So what I'm going to ask you to do when I open up the lines is you self-mute yourself, okay? Or I'll figure out a way to do that, I suppose. But we're going to have a conversation so you can speak live. So you've all been thinking about this, perhaps as physicians, but and who are not physicians, you've seen these sort of headlines around crisis standards of care, this idea who gets treatment, what's going to happen, we don't have enough ventilators. Coincidentally, my own hospital has more ventilators than the entire country of Pakistan. My hospital, one hospital in the United States, has more ventilators than the entire country of Pakistan. But I don't service at my hospital 300 million people. So this is not some theoretical concern, this is a real concern that we have to think about. Can you all still hear me? Yeah? Okay. So if you can't hear me, just send some chat or something so I can tell, because I don't know if someone's trying to call me because they can't hear. But in any case, what does this mean? So what do we mean by crisis standards of care, right? So crisis means easy, right? There's some extreme crisis, a hurricane, a pandemic, right? Or something that's a crisis that's affected, large swath or entire swath of society. And this comes together with the notion of scarce medical resources, that we have things such as blood, ventilators, drugs, vaccines, people, but they're in scarce supply. We don't have enough supply to deal with the crisis-related medical needs. So the conjunction of two things is scarcity and an extreme crisis, which leads to crisis standards of care. All right. Now, if you look at here, Chicago, where I am, this is defined by our Department of Public Health in this way, where methods of conventional or contingency care. So conventional care is usual care. Contingency care is you can have changes in care because of medical emergency, but there's no change in quality of life or quality of care. Sorry. Normal is I can give everybody the normal stuff, right? And quality of care. Here, contingency means that there's minimal impact. But crisis care, sorry, hold on. Give me 1 second. I don't know if you guys are trying to call me, but no. All right. Crisis here is that there's contingency, that methods of contingency and conventional care are not enough to meet patient needs. So crisis care aims to provide the best hospital care and the setting of limited resources. So we're going to get to the case in a second. Don't look at that. But this is what's happening now in COVID-19. So let me show you the slide, and then we're going to open up the lines. Can someone just tell me that you can still hear me? So imagine this is what we're facing now. or may Allah protect us, but we might be facing, that you have 3 patients who have COVID-19. And the question becomes, who is going to get in your hospital the last remaining ventilator? And 3 people need it. So you have a 28-year-old female, right? And they're all sitting in the emergency department waiting for you to make the decision who gets the ventilator so you can intubate them. So you have a very short time to make a decision. You have a 28-year-old female. She has some clinical indicators. They went through the algorithm in the hospital. If your medical record, you find out that her SOFA score, there's a score, and some physicians know what that is, says it's a 40% survival to 30 days. She happens to be 24 weeks pregnant. Okay, so now there's a fetus here who's at the level of viability, but she's got some history. She uses illicit drugs, and she's not ever presented for a prenatal. Then you have a second patient who's 80 years old, and you do their SOFA calculation, and their SOFA score is 6. So there's an 84% chance that they will leave be living in 30 days with the ventilator. However, this patient has advanced dementia and lives in a nursing home, but they happen to be the father of one of the executives in the hospital, one of the higher ups. Right? So you give it to that patient. Third, you have a 60-year-old male, right, whose SOFA score is 65. So there's a score of 10, that there's a 65% chance that they will be living at 30 days. However, he has COPD, lives on home oxygen, and continues to smoke despite being a COPD patient. However, one of the most prominent ICU doctors that you have, who's going to end up taking the patient, this is their patient. Sorry, so did you want me to go over the case scenarios again?
I think I was just really interested about the part where you're talking about when somebody is, when they're in a coma. That slides, please.
You want those slides up? Okay. I'll have to share my screen. Hold on one second.
Jazakallah. It's just that from there we actually lost you.
Okay.
And then it was breaking up from there.
Do you want me to start up from here again then?
Well, it's up to you if you have time, but we've actually lost you from here really badly.
Okay. So I'm going to speed through this and then we'll get to the case scenario. We probably won't get to the last thing that I want to talk about, then that's fine.
Jazakallah khairan.
Yeah.
Assalamu alaikum.
All right. So I was talking about the difference between coma and brain death, and I was saying that coma means 3 things, right? It's depressed alertness, attention, and consciousness. But the person in coma still breathes by themselves, and they still have present brainstem reflexes. However, when we think the person does not have brainstem reflexes, and they're not breathing by themselves, a definitely have to be different states. To sometimes equate them, but that's incorrect physiologically. Here, that what happens to a person in coma is that there's 2 things. Either the person they were before, or they are in a state consciousness, alertness, or attention, to commonly known as vegetative state and the conscious state. At the same time, it's different. Is that they will have a cardiac arrest. Shows this is around, I think, in 1 week. Most of the patients states, and we shouldn't confuse them when we're talking about withholding life support. And I was saying that the juridical councils have different views on whether or not brain death can be declared legal death in Islam, or should it be considered a state of a dying person, somewhere between living and dead, which they call unstable life, al-hayat ghayr al-mustaqirra. So that's the slide and papers I can share with you, but they're all over the place regarding that. 2 examples of a juridical council. Okay, let me look at the chat. I hope you guys are still getting me. Assalamu alaikum. Is this better? I can't do anything better than this. All right.
Wa alaikum salam. We can hear you.
Okay, I'm going to try to finish. I'm sorry, this is the Wi-Fi that I have available, and I apologize if it's not working good enough. I don't know what else to do. So I was telling you about the two different verdicts on brain death. I want to move on and say that that life, this purpose of this slide was that the life is of instrumental value, meaning that we should think about it from an Islamic legal lens. And those who talk about maqasid al-sharia should know this, because there's different constructions of protection of life in the maqasid. Some scholars say hifz al-hayat, meaning the protection of life. Others say hifz al-nafs, protection of personhood. And the reason, part of the reason why this is different conceptually is that life is of instrumental value. The life of this world is of benefit for the afterlife, right? And so we should recognize that when we think about an end goal of medical treatment or anything else, that it is to try to raise our ranks in the afterlife in Jannah. So we know this from the Quran, these two verses I've shared with you here, where Allah subhanahu wa ta'ala talks about the reason that we were created, being worshipped. And we know the idea of death, that there might be khayr in death. So Rasulullah sallallahu alaihi wasallam tells Sahaba in different narrations and different circumstances, who had asked him whether or not they could ask and make dua for death, that they shouldn't do so. But he gives them a dua to say, and I've underlined the relevant parts, that he says, oh God, keep me alive as long as there's goodness and life for me, and bring death to me when there's goodness and death for me. Note that in both constructions here, that there is a notion of goodness, khayr, in life and in death. And the idea is that you should do good works, right? Because there's goodness in life. So this is the idea of why life is instrumental and not of ultimate value within Islam. So when we think about end-of-life care decisions, we should think about them in light of how that remaining life can be beneficial. And to answer someone's question before, that is why it's important to think about advanced care planning and goals of care before you're facing that critical circumstance near the end of one's life. I'm going to skip this, and then we're going to talk about, and I'm not going to get to what perhaps Mufti Zubair covered, but I wanted to talk about with you all, if we can, this concern that we're having presently around resource allocation, right? Because we know that if COVID continues as it is, and people are in hospitals, that we do not have enough ventilators, critical care staff, and other things to provide adequate care for these individuals. And physicians at the front lines, as well as policymakers, are facing critical choices. So I shared previously, perhaps you didn't hear, but like my own hospital has more ventilators in Chicago, and just one hospital in Chicago, than the entire country of Pakistan. And this is not, right? So I think that may Allah protect our, the countries abroad, but there is going to be, even if we here in the UK or Canada or the United States are able to flatten the curve and get ahead of this thing, that the less developed countries are going to face severe challenges for months and even years to come. So the notion in the bioethical register is the idea of crisis standards of care involves two things. You have a crisis that affects a large swath or the entire swath of society. So examples are hurricanes or pandemics, earthquakes, bioterrorism, that affects everybody, right? And it's conjunctive to the other idea of scarcity of medical resources for servicing the healthcare needs from that crisis. So for example, you might not have enough blood or ventilators, drugs, or things like that. So when these two things come together, you have scarcity on one hand and a crisis that affects the entire or most of society. People have developed this idea of crisis standards of care. Within my own state in Illinois, we talk about this in this way, that conventional care can't be adopted, contingency care cannot be adopted, where there's some minimal impact of quality of care. But crisis care, there will be a significant impact upon quality of care. But what we have to do is the best care possible in the setting of our limited resources. So to make that more real for our participants on this webinar, in this class, I had presented 3 cases, and I want you to have conversation about this and give me some ideas. And we're gonna probably end with these few cases and not get to the last part of the talk. But here, imagine that you are like me working in the emergency department and you have to intubate 3 patients, but you only have 1 ventilator. And these are the 3 patients in front of you. One's a 28-year-old female who has a SOFA score of 13. And SOFA is a clinical decision tool that predicts mortality at 30 days for someone receiving ICU type care, in this case intubation, based on their clinical status, right? Their comorbidities, their blood markers, and so on and so forth. So we get from that algorithm that she has a 43% survival to 30 days. We know she's 24 weeks pregnant, so there's 2 patients here really, a child, a fetus, which is at the margins of viability. However, this female is also known to abuse illicit drugs and has had no prenatal care. Do we prioritize her over an 80-year-old male whose SOFA score is 6? So he has an 84% chance of getting out of the ICU in 30 days and living. However, at baseline, he has advanced dementia and he lives in a nursing home. The factor that we have to think about as well is that his father is a hospital executive at our hospital. So he's the father of one of the higher ups. And the third patient is 60 years old. His SOFA score is 10. So that means that there's a 65% chance he will be living at 30 days with the ICU level care we provide. But at baseline, he has COPD and still smokes, right? And the other thing to know about is the fact that he is a patient of the ICU doctor who's on call right now and is going to take care of the patient once you intubate. So which one of the 3 should we prioritize and why? So Zahir, so instead of you unmuting you, I'm just going to look at the chat box. You can type your comments and I'll kind of call you out. So it says, Zahir says, the first patient who has with the lowest SOFA score has the most to gain from treatment based on the subjective quality of life perception. The first patient with the lowest SOFA score. The second patient has the lowest SOFA score, the 80-year-old male. So what do you mean, Zahir? You mean the 28-year-old? Because she's got a higher SOFA score, which means less benefit clinically, less chance of benefit. Yes, so although she has, you're saying, although she has poor chance of survival, you want to intubate her over the 84 or the 80-year-old who's got an 84% chance of survival. What do others think? Just put your comments in the chat box. Zainab says she'll go as Zahir. And she's saying, because we're dealing with 2 patients here, and with the fact that there's a positive history of substance abuse, the child's at a lot of risk. So you want to save the child now? Is that the idea, Zainab? So you're saying that the 28-year-old female, she's got a poor chance, but because the child at 24 weeks, the viability there is also not assured. Adia says baby as well. Okay. So now we're not even looking at the 3 patients. We're talking about a future potential patient. What do others think? 80-year-old, why, Fahmida? AMAF says 80-year-old has already passed life average life expectancy, so whatever, it doesn't matter. Okay. Anybody else? Fahmida says the 80-year-old because his survival rate is high. Okay. Siraj says second patient. Same reason, Siraj? Ada says third. Why third? No, this is the only person who said third so far. Why the 60-year-old? Ada, why? You said the third, so why the third? Then we can move on. So the doctor will know how to treat him. Huh? Oh, the ICU doctor. So the point here in the slide is, okay, you know, this is interesting. I would not have expected the responses. I want to lift 100 weight. Okay. So on one level, you could say we should have, why this is red is we should just base it on the clinical criteria. Who stands to benefit the most from the treatment applied? And that would be perhaps the 80-year-old. When you go beyond that second point, you're actually making decisions about what life is worth to you. Someone said that 80-year-olds already lived most of their life. Who are you to judge? What does that mean? Right? I don't know what that means. The other people were saying, you know, there's 2 patients here. She's 24 weeks pregnant, but she has a chance of 43%. She's likely to die. Dominant probability, غلبة الظن, she will die. She will not live to 30 days. And now perhaps if this baby gets to 30 days more, it gets to 28 weeks, then you have a huge rate of survivability. But you're making her instrumental to the survival of the fetus, who might already have some issues because of substance abuse history. So I'm not sure why you would make this patient, who's the one that you have to think about, instrumental value to the next potential patient. At 24 weeks, some countries would say they're not viable until 25, right? You're getting right at that age. So you don't make decisions based on this patient, on this potential patient. And as someone said here, okay, the ICU doctor knows this patient, should we go here? Now, let me share another slide. So my point here was that once you go beyond the red, you're making quality decisions. Now let's think about life saved. Say you just said, I want to think about it just clinically. And what do we think about these scores? Is it lives saved or life years saved? So the 28-year-old, right, her expected life years saved would be 30. Given her comorbidities, right, she might live to, in her condition, she might live to 58. So if you apply this 43%, you're giving her a 43% chance that she'll live to 58. This 80-year-old, if he survives, right, gets to the 84% here, he will live another 5 years. And then the 60-year-old, their expectancy, life expectancy is 75. So do you use expected life expectancy? Remember, this person's got substance abuse history. They're going to have a shorter life than this person and that person. So should we prioritize lives years saved? Meaning that you're going to save 30 years of someone's life, not just the life itself. And here, right, and we're still not talking about the 24-week baby. But if you think that they're going to survive, you would add that to here, this as well. Or is it just life, a life is saved? This person has the highest likelihood to be saved. We just go here. Although they have the lowest expected life years after that event. So even the clinical becomes a bit complicated. Okay, all right. So I'll tell you that this is a challenge from the ethical standpoint, bioethics standpoint. I'll talk about Islamic musings in a minute. Right, so if you say maximize benefits, because that's what we're trying to do, then some would say save the most lives, which I just said, save the most lives. The person's got the highest likelihood of living would be the second thing, save the most life years. So either you give it to the 80-year-old, save his life, most likely, or most life years, right? Which might be, in this case, not the 28-year-old, but actually this person, because they're greater than 50% here of surviving. So I'll apply it to the third patient. Now, others might say, no, treat everybody equally. Why are we making judgments about people's quality of life, right? And about life years? We'll just give the first person first. The first person comes, they get the ventilator. And the ethicists say you shouldn't use that because they think that privileges, people live closer to hospitals, and you're not taking any clinical indicators into account. So that's what this is a New England Journal of Medicine article by 𝐁𝐚𝐿𝐿. He says no. Others say randomly decide, right? So once you have the same SOFA score, then just flip a coin. All right. A third sort of register is no, we should think about the intrinsic worth, instrumental value of people to society. What do you mean? Well, how beneficial is the person who you might save to society? If you think about it retrospectively, one would say, well, the people who have participated in research, right, to make us now have the ability to prognosticate SOFA scores or to have new treatments, they should get priority because they, retrospectively in the past, they contributed to societal gain that might help us treat patients in the future. Or healthcare workers who are doing right now their utmost to help save lives. That's retrospective, right? So someone who got sick because they were taking care of COVID patients is now in the ICU and needs to be intubated. They bore the risks, they should get the treatment over other people. Or someone might say prospectively, not what they did, but what they would do. So people who are healthcare workers will not only have a retrospective benefit that they did this, but they might in the future help others. So that's the other idea. You reward and promote and prioritize instrumental value, benefit to society. Another way we think about it, we're giving priority to the worst off. So who's the sickest, right? We give it to the sickest person, regardless of their chance of living, sickest person. Or youngest, because they have most years to live, right? So you want to maximize the benefit. So these are all different ethical rubrics to take into consideration. Now, this was a paper in New England Journal of Medicine. Another person wrote a paper in Lancet, and they had a different view. They said, no, we shouldn't use one principle. We should use many and balance them. So the principle of, and what are the challenges with these principles? So equity, giving everybody equal chance, right? So that would be here, first come, first serve, or whatever. Well, this is a problem. You can't treat everybody equally. They're all different people. Even in the case I gave you, the 3 cases, they're all different people. They have different sort of responsibilities. Prioritize the sickest first, but that means that people who have less chance of survival, you're giving them the treatment or the intubation. That's a problem because then you will not use it for the best possible outcomes. Or the youngest, well, why do you prioritize the youngest over the old? What if someone's 60 and is the president of a country or the healthcare minister and you want to give it to the 6-year-old instead? Why? You're discriminating against that person. Utilitarianism, meaning maximizing total benefit, well, then you will now underprivilege people who you think are worth less, right? Meaning the janitor who lives with 10 people, you know, why are they not treated equally? Or the marginalized people, the disabled people, why? Why would you discriminate against them? You only exacerbate existing inequalities in the social status. And then this idea about instrumental value, social usefulness, well, this is subjective, right? How would you know? And why would you do that? So this is also problematic from his view, or these colleagues that you know, we have to balance all of them. We can't use one or the other. Now I'm going to stop. Oh, how are we in time? Good, we have just 13 minutes. So I'm going to stop, I think, with this slide. I want to share with you some musings on this, right? From an Islamic perspective, one could say that if you're just going to use a clinical benefit rubric like SOFA score here, we should know that people, specifically with intubation, I already shared this with you, that less than 50% will survive to 30 days. So the dominant Islamic ethos here is for minimizing harms, not procuring benefits, because the benefits are fleeting. We also know that intensive care involves harms to human dignity. This is a qualitative, subjective sort of idea. But if you put yourself in an ICU where you can't clean yourself, you can't take care of yourself, you have to be intubated, that means you have to be sedated most of the time. One would say that I feel this is not the highest possible quality of my life. Therefore, there's no obligation to initiate when these two things come together, because clinically, there's less than 50% chance that it's beneficial. We talked about when you are mandated to seek medical treatment. This is not one. And then actually, it's permissible to withdraw here or withhold. And because harms are now accruing, those harms can outweigh the possible benefits. Therefore, clinical rubrics are actionable, right? And you can use them to deflect harms and procure benefit. The idea here would be to actually withhold where possible and ask families and patients to think about them themselves. So that's the notion of clinical rubrics like the SOFA score. Next, what about privileging one person over another, right? And scarcity. Well, yeah, it's true. Some individuals may be more beneficial to society, right? Some people might be more like healthcare workers, for example, right? You might say that they're more beneficial to society. And in various sort of fiqh manuals, you can see perhaps this notion. Other issues are, there might be people, they talk about, for example, someone who's more dependent, like someone's got 10 dependents, right? Versus someone's got 1 dependent. they're more not beneficial to society, but if they were to die, they would leave 10 dependents as opposed to 1 dependent, and we should now, in this case, minimize harms to society and to those children. So you might use that idea. Or some might say, yeah, the young, because this is just how innately our intuition, our inner selves always, our parents want to privilege their children for eating when there's scarcity of food. So this is consistent with an inner ethos, right? The fitrah sense that children should be privileged. These are all sort of dhanni views here, meaning that we can all make arguments, but it's perilous because they're not tangible necessarily. Some scholars might argue for certain things, but you have to think about them very carefully because there's a slippery slope there. Lastly, the idea of just prioritizing flipping a coin when clinically is equal, and I want us to shift our frame of thinking. Well, when you just flip a coin, are you actually absolving yourself of decisional responsibility? Are you saying, well, look, I don't know what to do, let Allah subhanahu wa ta'ala decide here? So for us, when we think about legal actions, as I said to you, you have to think about theology and ontology here. Rasulullah would use lots, right, to pick which wife's house he lives in or takes it with him to battle. Right? We have these notions within our tradition where prophets even use this idea, not the lottery for money, but this idea of picking lots. And so this, in my view, is not a non-action. It is actually a recognition, a humility of I can't decide this. It's too perilous for me to decide, and I'm going to let Allah subhanahu wa ta'ala decide here what the action is. So I'm going to stop sharing my slides because we're not going to get to what Mufti Zubair talked about, and which is fine because of all the issues. And we can just have a conversation here, inshallah, through the chat box. We have about 9 minutes. So questions, let me look at questions. No, there's no questions, okay. Is someone talking? I can't hear. If you find yourself in a war and you have to choose between taking wounded or dead, I think you should take the wounded. Okay, sure, if you say so. I don't know what that means here. Are there questions, comments? I don't know exactly how to unmute people, but I can try, or you can just type your stuff in the chat box. Does the fact that the second patient is related to the higher up make a difference? Well, it makes a difference to that patient, right? I mean, we all have this idea of VIP care. So sometimes VIPs get different levels of care. Does it make a difference to me? I mean, should it make a difference? Well, in our lives, always people who know people get privileges, and I'm not sure that in this case you should in crisis allocation. I would argue both ethically you shouldn't. In your example, who would you choose? I would make dua that I don't have to choose, but I think you go by clinical benefit, right? So I find it for myself very challenging to say that I'm going to privilege one person's life or another because of some qualitative notion. So whoever stands to clinically benefit more, in this case there were 2 patients, one had an 84% chance of survival, the other had 65, would pick the 84%. Okay, next. Is there any difference between what the medics have said so far and the Islamic stance in regards to treatment when faced with scary sorcerers? Yes, I just shared with you, right, that there are various ethical notions of privileging those who are beneficial to society. That's a clear issue. healthcare workers or the young or someone else, right? And there are differences in views. I mean, it's not like there's one view, there's many views. And they all could be objectionable. Sometimes there can be objectionable notions there. There's no, first of all, there's no the Islamic stance either. Just like there's multiplicity of views within this quote unquote secular world, there are multiplicity of views within the quote unquote Islamic world. All right, so that's your response, you Siraj. Then Zahir, sorry. Has COVID made these decisions easier or harder based on the dismal recovery figure once patients ventilated? Well, I haven't, I think that it depends who you're gonna ask. From my perspective, it makes it harder. Scarcity only makes it harder. But we need to, and you all need to sort of have conversations with people to think about what they would like so they can make it easier. Yeah, and 3 doctors, that's also similar to what Saudi does. Nadia. Abdullah, he says, can HCPs refuse to take care of patients on PP not available or declare responsibility? It depends what your contract says. So ethically, from a medical ethics standpoint, you don't have to sort of, so let me say 2 things. From a medical ethics standpoint, one could say that I don't want to put myself in harm's way and I'm not obligated to do so. From an Islamic standpoint, you could say that this communal responsibility is fard ayn. Medicine is a fard kifaya, not a fard ayn. So for me to work is not wajib. Now, contractually, if it's like, no, it's your contract say you have to work and you have to take this responsibility upon yourself, then that might be a different issue. But you have to look at your contracts. Can a doctor take decision based on personal judgment even if it's against flawed protocol? I don't know what that means. If it's against protocol, again, your contract would tell you, and sometimes you can't do that, right? Okay, can I say no to recession baby because my own life is at risk? I already answered that. I mean, it depends what your contract says here. I apologize again that my sound wasn't very clear earlier. Anything else before we close up, inshallah? All right, okay, so inshallah I will end here. And again, my apologies. I wanted to talk a little bit about Jumu'ah and stuff, but I heard some of you, Mustafa Zubair, took care of that, so I don't have to talk about it. And inshallah, you know, may Allah make it easy for all of us, keep us in your du'as. May Allah subhanahu wa ta'ala protect you all and protect us all and lift this Balagh from us. We're still in the final days of, you know, of Sha'ban, so, you know, make the dua that Allahumma barakhna fi Rajab Sha'ban wa balagh Ramadan, and keep us in the du'as. All right, I'll take care, everybody. Assalamu alaikum wa rahmatullah.